Okay, so I'm going to talk about bloodletting practices in the U.S. Just kidding. But now that I have your attention, I have no disclosures to make. Our objectives today is to understand the diagnostic criteria for pediatric bacterial rhinosinusitis, understand the utility of imaging, as well as the treatment options. So to kind of review the anatomy, there are 4 paired sinuses. There are the maxillary sinuses, the frontal sinuses, the ethmoids, and the sphenoids. So the things to remember is that in kids, the maxillary and ethmoid sinuses are pretty much the most developed at birth. And so they're the ones that are going to be most relevant to in younger kids. The sphenoids start to become imageable by around age 3 to 5, and then they don't get fully developed until about early adolescence. The frontal sinuses aren't typically present at birth, and they start to become aerated around 5 or 6, and then reach adult size by about late adolescence. So this is relevant because in kids under 13, they're treated a little bit differently from kids over 13. And over 13, they're more like adults. So the diagnostic criteria, verbiage is a little bit different in the different organizations, but luckily they all mostly agree with each other. So it's mostly based off of history. If you have persistent illness, meaning nasal obstruction, nasal discharge, and cough that lasting over about 10 days without improvement, or you're having a double worsening, so you're starting to get better and then you're worsening again, or you have a severe onset with a fever over 102 degrees with purulent nasal discharge for at least 3 consecutive days. Now, one of the biggest differences between kids and adults is that in kids, cough is a lot more of a significant factor than loss of a sense of smell compared with adults. And the differences between acute, subacute, and chronic is mostly just time. If it's under a month, it's acute. If it's 1 to 3 months, it's subacute. If it's over 3 months, it's chronic. Recurrent acute, this is more for adults really, but it's 4 episodes within 12 months. And then it's important to differentiate, of course, upper respiratory infections that are viral versus bacterial, because 6 to 8 episodes a year for kids is average for upper respiratory infections. And then about 5 to 10% of those go on to become acute bacterial rhinosinusitis. And so when it goes on to become chronic, it becomes a fair amount of disease burden, about 5.6 million visits per year. And then on quality of life questionnaires, they found that kids who had chronic bacterial rhinosinusitis that were about to go to surgery, you ask them what their quality of life is, and they actually had lower scores than all the other chronic pediatric diseases, including ADHD, psychiatric disorders, juvenile rheumatoid arthritis, epilepsy, and asthma. So this is a fair amount of disease burden here. So again, most of it is based off of history and not imaging. And so the American Academy of Pediatrics actually has a strong recommendation not to image kids to try to distinguish acute bacterial sinusitis from a viral upper respiratory infection. And the reason for this, there was actually a study that was done that imaged basically everybody within 3 days of an upper respiratory infection, and 88% of them had mild to severe abnormalities on CAT scan. And then you think, well, maybe I could just get a plain X-ray. And while that does have some utility, they are fairly inaccurate. So this is not the same kid, but this is just an X-ray versus a sinus CT, just to kind of give you the differences. You can see on CT, if you see kind of black going right to white, that's a pretty clear sinus. The other side, obviously, not so much. So if you compare plain radiographs versus CAT scan in a prospective study of 70 kids with recurrent sinusitis, about 75% of them did not have x-rays that correlated with their CAT scans. So 45% of them that had normal plain x-rays had at least one abnormality on their CAT scan. And the converse, about 35% with abnormal plain x-rays had a normal CT. So the conclusion is that you can over and underdiagnose sinusitis on plain radiographs. So if you do end up getting imaging, usually we go for a CT of the sinuses or maxillofacial CT. Usually we do it without contrast unless we're suspicious of some kind of complication like an abscess into the orbit or brain, to kind of reminisce on our 8:30 Dr. Amami's talk about complications. And if you are thinking, if it does look like there's complications like that, we would actually consider an MRI as well. And a negative CAT scan that does not show sinus disease effectively rules out sinusitis, okay? And in kids, I am pretty careful about ordering imaging because of this 2012 study that says that, yes, you can have a slightly increased rate of malignancy, about one additional case of leukemia or brain tumor per 10,000 CTs of the head obtained in childhood. That doesn't mean I don't get it, but just to be careful about it. And so when do I order imaging? When we are starting to think about going to sinus surgery. And in kids, this doesn't happen all that often, and I'll talk about why. So we want to evaluate anatomy and extent of disease because we're thinking about sinus surgery. And usually when we're doing that, if you have a negative CT and you've completely ruled out disease, that's helpful as well. And of course, complications of sinusitis like the swollen eyeball. And if you see a kid with a swollen eyeball, CAT scan to try to figure out if there's sinus disease that's doing this versus is it just an orbital or an eye complication. Okay, so management, allergies is an important part because a lot of kids might actually just have allergies, since a lot of this was based off of just history. Usually I will go ahead and manage their allergies, put them on a nasal steroid spray, choose some antihistamine, see if it goes away. If that seems like it's their primary problem, sometimes even allergy testing or even immunotherapy, which incidentally, in children, putting them on immunotherapy can sometimes help to prevent or decrease the incidence of going onwards to develop asthma. Nasal saline is a wonderful adjunct. And really, this just helps to increase mucociliary clearance. It helps symptomatically. Nasal steroid spray has anti-inflammatory effects as well as potential decongestant action. Systemic steroids, not usually for uncomplicated acute cases, but certainly as part of a treatment plan for chronic, where we're trying to figure out, do they need to go to surgery, try to treat them to help to get them back to normal. If possible, a culture-directed antibiotic therapy. We usually head towards inside the nose. Just, runny nose isn't super helpful. You want to try to get it as it's coming out of the maxillary sinus and in the middle meatus. And then there was a consensus statement put out by the AAO, so our academy, the Otolaryngology Academy, that for chronic sinusitis, a 20-day consecutive course might give you a superior response than a 10-day course. So a little blurb about nasal saline. It has been shown to decrease symptoms of both allergies and sinusitis. These are mostly done in adults, but on a questionnaire, SNOT 20, yes, a real questionnaire called the SNOT 20 score, sinonasal outcome test, a validated questionnaire that just basically asks questions like, does your nose run and how severe are these symptoms? And it did show that just nasal saline by itself reduced those scores. And in kids, we don't tend to do it because most people don't think their kids are going to tolerate it. So what did they do? They actually did a study on whether or not kids tolerate it. So this says here, they divided, they took, I think it was about 70 kids, and they divided it by age, under 5, 6 to 12, and over 13. And they said, the first line is, did you think your child would tolerate nasal saline irrigation? And most parents did not think their kids were going to do it. This was the total score. And then this number here is how many of the kids actually tried it. I guess the under 5-year-olds had no choice because 100% of them did it. The teenagers were less likely to try it in the first place, but they got most people to try it. And then, did your child actually tolerate nasal saline irrigation? And most of them did, over 80% total. And then did it help improve your child's symptoms? And agreed, most of them, it did help improve their symptoms. Okay, so this one. So it occurs to me that maybe most people don't know what it looks like to do nasal saline. So it's pretty simple. Most things, they come, there's Neti Pot, there's Neilmed, there's Kaido Rhino, there's all sorts of products out there. That's essentially you put in this salt packet. A lot of them come with these little salt packets. You just put it in. You add some clean water, like distilled water, reverse osmosis. In the United States, tap water is usually safe, and I say usually because if it gets contaminated, it is not safe to put up the nose. So generally speaking, if it's not safe to drink, don't put it up your nose. Okay, I invited one of my next door neighbors' kids to demonstrate for us. All right, so the key to nasal saline, a lot of people say, I feel like I'm drowning when I do this, and it's because they're trying to breathe through their nose. So if you breathe through your mouth, she's doing it kind of quietly, but she's got her mouth open, she's breathing through her mouth. That closes off the nasopharynx so that that water is just going through one side and running out the other. She does not have a septal perforation, okay? This is going all the way to the back of the nose and coming out the other side, and you're just breathing the whole time. You can go through all 8 ounces in one go. Okay, so common pathogens, strep, pneumo, H. flu, catarrhalis, staph, these are all the common things we all learn about. And then antibiotic choices, amoxiclav is still considered first line. You can also do Omnicep. With beta-lactam allergies, you can consider other things, Bactrim, azithromycin, clarithromycin. In older kids, you can consider quinolones, doxycycline. So additional considerations. One of the biggest differences between kids versus adults is adenoiditis. And more about this later. And of course, allergy can have a significant role. So in kids, if they're starting to have a lot, if you're going to have chronic sinusitis or a lot of infections, I will also consider screening them for immunodeficiency. And of course, small percentage of kids will have cystic fibrosis. These are usually all lung problems, ear problems, as well as sinus issues. And if that's negative, I would also consider primary ciliary dyskinesia. Also important to remember that your maxillary sinuses are just above the maxillary dentition. So if they've got really crummy teeth, consider sending them to the dentist and make sure that they don't have an odontogenic source, which of course you usually have to take care of the sinus issue as well as the dental issue. Reflux. About 15 years ago now, laryngopharyngeal reflux came on the scene, and then ENTs got very, very interested in this whole reflux causing ear, nose, and throat problems. For a while, it seemed like reflux was the root of all evil. The fervor has since died down. So yes, reflux can sometimes cause some inflammation, but unless they actually demonstrate reflux symptoms, there's no recommendations to just empirically treat for reflux. So comorbidities, out of over 4,000 patients, 26.9% also had allergic rhinitis, 12.3% also had immunodeficiency, 4.1% cystic fibrosis, and then much lower, 0.2% had primary ciliary dyskinesia. But just some things to consider that maybe it's not just treat with antibiotics, maybe you have to think about underlying conditions as well. So adenoids, I mentioned that this is a much bigger role in kids compared with adults. So some of the data that went with that, they took a bunch of kids who had to take out their adenoids, and then they imaged them. Now, granted, I told you that x-rays were not that sensitive, or not that accurate, but the trend was there that if they had more sinus disease, so they graded it 0 to 3, more sinus disease, they also had more bacteria that was isolated in their adenoids. Of course, that wasn't the only study. They also another study, they just looked at kids that had sleep apnea versus that they had their adenoids out because of chronic rhinosinusitis, and they looked at the adenoids with electron microscopy, and they scanned it for the presence of biofilms. And the kids with obstructive sleep apnea had very low surface area of biofilms. The kids with sinusitis had very high percentage of biofilms, and this was statistically significant. So in kids, first-line therapy for bacterial rhinosinusitis is actually to take out their adenoids. In under 6 years old, this is the American Academy of Otolaryngology had an expert panel, and they did reach a strong consensus that this is an effective initial surgical therapy for kids under 6. Between 6 and 12, there was less consensus, but still agreed that it is helpful. Over 12, not so much. Again, they're treated more like adults. Now, if someone comes in and they've got nasal obstruction or runny nose, yes, you would consider just checking a lateral neck x-ray to check how large the size of the adenoids is, and you would consider taking out the adenoids just because they were obstructed in the nose. But if they have chronic sinusitis, you don't need to check for a neck x-ray because the size does not correlate to the presence of sinusitis. So if they're coming in with a good enough history for that, I don't need to check an x-ray because it doesn't change what I'm going to do. I would probably still go take out their adenoids. And then, of course, if they are failing all the medical management, once in a while we do have to do sinus surgery, endoscopic sinus surgery. It has been shown to be effective for failure of medical treatment or after adenoidectomy. In the past, we were concerned, based off of animal studies, that it could retard facial growth, but that has not been shown to be the case in humans. Little brief blurb, over the last probably decade or so, balloon sinuplasty has also been gaining some favor. And in the pediatric population, the idea was to try to preserve tissue. So in case you don't know what that is, it's basically we take a wire and we put it in through the natural ostium, and then we snake a balloon over it, and we dilate. And we're just widening the natural ostium there. Versus in normal sinus surgery, you would be taking down walls and making really wide openings. So this is just a quick video. This is the middle turbinate here. This is snaking in that balloon, and you just blow the balloon up. So normal sinus surgery, you'd be taking this down. You'd be removing that tissue there. And that's it. That's balloon sinuplasty.
How long does that last for?
Oh, it lasts. And if you fail balloon sinuplasty, you can go on to the regular FES.